It's such a beautiful sunny day out there, and this is such a crowded time of year that we really appreciate you turning out for this, the fourth in the series of 4 Voices from the Vanguard lectures. You know, my partner in crime, Dan Cawley, who is the director of the Center for Tropical and Emerging Global Diseases here at UGA, and he's sitting down here in the front row. We really can't thank you enough for your continuing participation in this lecture series. It's been a great reward for us to see you all here, and I know some of you have come again and again, which is just great. There are a few thank yous that I'd like to issue at this last lecture. First of all, to the Office of the Provost, without whose financial support we wouldn't be able to do this. Franklin College, we appreciate being recognized as a blue card event, which I know brings some of you here to us tonight. I'd like to thank Professor Julie Moore, whose People, Parasites, and Plagues course also motivates many of you to join us. That's a great course. These events do require some technical expertise, which is certainly not my area, and for that we owe 2 people from Grady College who do this over and over again and do it so smoothly. Diane Murray, our Director of External Affairs, who's down in the front, and Anitra Mapp, the Administrator for the Night Health Programs, who's watching from up above. If you would just join me for a minute in thanking them for everything they do. I'd also like to thank the Grady ambassadors who time after time hand out the programs and add a note of class to these events. Tonight is really special for me. It brings together 2 of the world's leading experts on communicating with journalists. I've been in hundreds of press conferences as a reporter, and you know the difference between the good public relations or news office people and the not so good ones. And we have two of the very best with us tonight. Not just Dick Thompson, our featured speaker, but also Dr. Vicki Freimuth, who's going to introduce him. We're so pleased to have Vicki here at UGA. She not only has a deep theoretical and academic background in health and risk communication, but she's walked the walk. She was the director of the Office of Communications at the Centers for Disease Control during the anthrax attacks, during SARS. She lived through some pretty exciting times there. So let's get Vicki out here, and she'll tell you something about Dick.
Thank you. Since tonight is the last in the series of this year's lectures, I'd really like for us to take a moment to recognize the work of both Pat Thomas and Dan Cawley, who have been organizing this fascinating series. So if you'd join me in thanking them for their work. And Dan, you want to... Thank you. I'm particularly pleased that tonight the organizers have chosen to include a risk communication expert as one of the featured speakers in this series. Too often, communication is overlooked in crisis planning, but it's always the thing that gets blamed in the after analysis. And I think once people and organizations have been through a crisis, they begin to recognize what the important role that communication plays. And we are very fortunate that that field is very well represented by Dick Thompson. His responsibility is truly awesome, and this is from someone who felt like her responsibility was awesome. But he must break the bad news about infectious disease to the entire world, which is a very challenging activity. I first met Dick in 2001, right after he had taken this position at the World Health Organization. I was, as Pat told you then, Director of Communication at CDC, and we were all in the middle of one of a series of crises. This time it was SARS, and I actually didn't know until today that apparently Dick is credited with coining the label for SARS, and I didn't know that until I read it today. I especially have appreciated since that time the leadership that Dick has shown by gathering many of the risk communication experts across the world and having them develop a set of best practices for outbreak communication. And these practices are being used and disseminated throughout the world, and he's doing a lot of that work. Before Dick joined WHO, he was a science reporter and a war correspondent. He worked for Time magazine in San Francisco and then in Washington, D.C. Dick has the unique perspective of having been a reporter for a major news organization and now the spokesperson for a major international agency. I'm really looking forward to hearing him talk about breaking the bad news. Please join me in welcoming Dick Thompson.
Thank you very much. Let's see if I can get this off. And turn this on. Thank you all for coming. It's after midnight in Geneva, where I live and was until yesterday, so I needed a little pick-me-up here. It's hard to be described as a communication expert, especially a risk communication expert. I guess that's true, but it also tells you a lot about risk communication experts. We seem to come from very diverse fields. There's not the kind of training that we would hope to be in place and that we're all moving for right now. People learn pretty much on the job as it happens. Just to tell you a little bit about, because I'm supposed to talk about myself, about how you get to be a risk communication person. My first professional job, one I had for 10 years, was as a bartender. And I worked in the restaurant business for a long time, sometimes substituting as a cook. And I learned something that was really very important as a communicator. And I think it's something that's lost on a lot of communicators, and that's the ability to listen. We spend a lot of time thinking about messages, but we don't often think about listening. So being a bartender was my first life. And let me see if I can make this work. This was my second. I worked with Time magazine for a very long time. This was actually the last cover I did about the human genome. I wrote a book called Volcano Cowboys, which I found is not in your bookstore. It's also crossed the 1 million mark on Amazon, so it may be hard to find anywhere. I was a bureau chief for Time in South Asia, which meant that I covered a number of conflicts in that area, including the fall of Kabul. I covered several administrations, worked in the White House a lot, got to fly on both the old and the new Air Force One. So I had a broad background as a journalist. And that was my second life. It came to an end in 2001 when my magazine was acquired by America Online. And I entered journalism at a time when I thought it was a very robust field that was driven by ideology. I went into journalism I went into college in 1971, and in college during the Watergate era. And it was a time of high ideals and noble purpose. I felt that journalism was really an important function in a democracy. I still feel that way. I'm a little sorry about what's happened to it, and I think what has happened to it is that it's become much more of a business than it used to be, and this has changed the face of journalism. But I was fortunate enough in 2001, when I was offered early retirement, to have a friend of mine who worked at the World Health Organization ask if I wanted to come and work for the World Health Organization. And without knowing much more about it than it was in Europe, which I thought had long vacations, short work weeks, and was a pretty comfortable lifestyle because you could get to Paris in 3.5 hours, I decided to take that job. And this is what I do now. Nope, that's not it. This is it. The idea of breaking bad news, I think, is contained in this cartoon. I don't know if you can see it. It says, "We interrupt this emergency breaking news bulletin with an even scarier emergency breaking news bulletin." I deal in outbreaks, outbreaks of international importance. These are small epidemics, localized epidemics of diseases like SARS, Ebola, plague, anthrax, Marburg, Usually they erupt in Africa, parts of Asia. We spend, I'll get this right soon. We spend a lot of time thinking about what makes outbreaks special and why do they offer such special communication challenges. Because a number of countries have found it difficult to announce that they have an outbreak. This is the very first step in controlling an outbreak, because if countries don't announce that there's a problem, then we can't really respond. We can't begin even the basic epidemiology. We certainly can't begin responding. We came face to face with this after our experience with China and SARS, in which China delayed for such a long time the very fact that they had hundreds and thousands of cases of cases of SARS. So we wanted to find out what is it about outbreaks that makes it so difficult for countries to talk about. And we looked a long time at these outbreaks, and they have, I'll get this right, outbreaks have several unique characteristics, or so we thought at the time. That these are events that begin and we don't know where they're going. They unfold before our eyes. Is it a single case of anthrax, or is it just the first case of anthrax? Is it the first outbreak of Ebola? Is it localized? Is it spread? So when outbreaks happen, we really don't know the dimensions of the outbreak, and it'll take some time before we know that. And they're also unpredictable events. You can come very close to controlling an outbreak. You can be very confident that it's nearly over, and the next thing you know, you have a new outbreak of the same disease 10 miles away. This happened to Toronto. They thought that they had SARS under control in one area. They came to Geneva, asked us to lift a travel ban. We did, and then they had another outbreak. So they're very unpredictable, and these two features, being unfolding and unpredictable, are probably the most important. There'll be a third one I'll show you in a minute. Are probably the most important when it comes to countries announcing outbreaks. Because even if they want to announce, they want to know that they have their facts in front of them. And you can't know that in the beginning of an outbreak. You cannot know it. And that means that countries have to say, I don't know, but this is where we are at the moment. This is the information we have now. And that's very, very difficult for countries to do for lots of reasons. Because behavior plays a key role in transmission, but more importantly, because there are social and economic consequences. And that means political consequences to announcing an outbreak. So an outbreak isn't just a public health event. It can be an international event. It can be an economic event. It can hurt trade and tourism. It can hurt a country's standing, how it's seen in the world. And this creates a sense of anxiety in the public. But as we looked at this, what we found was the more important anxiety is in response managers. They become very, very anxious. And what they try to do in their communication is to reassure the public. Yes, we're worried about this, but we don't want to create panic. I can't tell you how many times we've heard that we don't want to create panic. So we're going to mislead the public. We're going to say that we know something. We know the dimensions of the outbreak, or we know how to control it, something like that. And then very shortly it's seen that they don't know how to control it. And so they lose credibility from the start. And these are always newsworthy events. Very often countries that I deal with, in Africa and Asia, will say they know how to control the press, and they do. There's no doubt about it, unless there's an international event, because international events bring in international reporters. And so the normal way that they've been dealing with the press, issuing a statement that may not be right, whatever, that's been carried in the press is now subject to a new scrutiny. So this will cause them some problems. Okay, so this is where we begin our day in Geneva. This is the Outbreak Response Room. It's called the Strategic Health Operations Center, SHOC. And we actually used to meet in a much smaller, more unpleasant room. But after SARS, we were given some money to create something like what they have at the CDC in Atlanta. Each morning at 9 o'clock, we'll have disease experts sit around this table, and they'll go through the overnight reports of outbreak confirmation, rumors. We'll get a better understanding of where we are with an outbreak. We'll get reports at least once a year and sometimes twice a year of a smallpox outbreak. Smallpox has been eradicated for 30 years or so. Nevertheless, we keep getting reports. So what we have to do is to verify the reports, and that starts in this room. Each report is assigned to one of the disease experts. They'll contact one of our country offices. They'll ask the Ministry of Health for about what's going on. And then we'll begin a process of either assisting the country or discounting it as a false rumor. So this is an example of an outbreak that we would get. We began in early 2005, we began hearing reports of demonic plague in a place called Ituri. Ituri is up in the northeast of the Democratic Republic of Congo. There was a large pit, not as large as your stadium, but a large pit where somebody had discovered a diamond. Overnight, something like 7,000 people moved into this pit searching for diamonds. They're in an area about a quarter of the size of your stadium. They're digging around. They spend all day in this pit. They're coughing, there's plague in the area, and plague gets passed around. Now, as soon as it was confirmed that it was plague, 4,000 of those people vanished. They just went away. They disappeared back to their hometown. So what we had to do was to try to track down where they'd gone. We had to alert people. We had to let them know if they were sick that this is what they should do. We had to get medicines into the area. So this is pretty typical outbreak response. Not a typical outbreak response. This is a picture of Weege. Weege is in northern Angola. This is an area that has been pretty much devastated by 25 years of civil war. It's close to the border with DRC. There are something like 10,000 landmines still in the area. It's a very difficult, remote place. In early 2005, we got a report indirectly from an Italian pediatrician. There was an Italian NGO working in the area. And this woman had a number of children who were dying every day on her. And they were dying with unusual fevers and bleeding. She managed to get a sample out. It was sent to the CDC, where it was confirmed to be Marburg hemorrhagic fever. Angola asked for assistance. It's interesting that one of the first types of assistance that they asked for was communication. And this is something that happens more and more frequently now that countries know that this is available. They didn't follow much of the advice that we gave them, but they recognized right off that they did need communication assistance. This is Dr. Pierre Formanti. Like many people at WHO, he comes to us from MSF. He's probably, I can't think of anyone else who has more experience in the field dealing with hemorrhagic fevers. He is a father of two, and I don't think he spent a Christmas with his family in the last 5 years because for some reason hemorrhagic fevers seem to erupt in the wintertime. So he's often in the field. He looks a little concerned here, but I think he's trying to impress upon these people the importance of wearing this equipment. This is personal protection equipment. Whenever a person is infected with a hemorrhagic fever, they become more infectious the sicker they get, and they're most infectious at the time they die. This is a problem especially for families that go through traditional burials of people because they spend a lot of time touching the body and preparing the body for burial. In some cultures in Africa, it's important that everybody who knows this person touches the body because that shows that they didn't place a curse on that person. That wasn't the case in Ouija. In Ouija, there was a ritual pouring of water over the body, and then those people attending the funeral would drink this water, thus spreading the disease. And this Ouija eventually became the largest outbreak of hemorrhagic fever that we'd ever seen. This is what happens in the field. You see a person here who's just taken a throat swab from this person has died recently. He's taken a throat swab from this body, and he's preparing it. Canada had set up a mobile field hospital, which is probably unique in the world, I think, because it requires a safety level that's a very high level, and it's hard to deploy in the field. So this person will take a sample. As you'll see, the body has to be carefully cared for, and especially during burial. We bring in anthropologists to these kinds of situations so we can understand what the burial rituals are and offer substitutions. In areas where people have to touch the body, we can say that the spirit of this person has been transferred to a tree, and if you touch the tree, it's the same thing. And this actually works. It's a kind of communication challenge that you get a range of communication challenges in my job. Another communication challenge is that these people are wearing white. We didn't realize it at the time, but white is a symbol of witchcraft. And this created a huge problem. The other problem here, let me jump ahead, is that this is how people would leave the WHO Emergency Center. It was very important that we would confirm that everybody had put on their personal protection equipment properly, even though it was 105 degrees, and that they would be driven out to the site. Actually, it wasn't very long before people started stoning these trucks, and it became very dangerous for them, and we had to stop our work. And it didn't happen here, but in other places, hemorrhagic fevers can be very dangerous for healthcare workers. They've actually been killed. And the reason being is that families are encouraged to send their sick loved one to the local hospital. That person will go into the hospital and die. And people naturally start thinking that something is happening in this hospital that's killing my family. And the people doing the killing are the people who work there. So it is unusual. It does happen that people get killed. Healthcare workers are killed during hemorrhagic fever outbreaks. Emotions run very high. This is a new and extremely difficult disease that people have. But by listening to what's going on, which we now think is extremely important, we can respond to factors that most people would consider irrational. And that's an important thing about listening and about communicating. And you often hear things that won't make sense to the technical side. During SARS, a lot of people, especially in Asia, started wearing masks. And we were asked to comment about that. And I went to our technical group and I said, what do you think about these surgical masks that are open on the side and have cute drawings on the front? Are these actually preventing any illness? And the answer was no, certainly not. I mean, there's no eyewear, there's nothing, the masks are open, it's not a good thing to do. And so as a sound technical person following our technical guidance, I went out and said, you're really not protecting yourself. I hope I wouldn't do that again. because it was a huge mistake. What people were saying and what I wasn't listening to was the fact that people wanted something to do. But I'll talk more about SARS in a minute. They wanted something to do to protect themselves. So once we finally figured out that this kind of scene was frightening to people, we had them dress in their personal protection equipment outside the home that they were visiting. So you would show up, you would see somebody that looks like your neighbor, and you'd see them put this on, and things got much better from that point. Well, things got a little better from that point. There were traditional healers who actually began selling a potion that would protect people from Marburg. And if your family member had it, and if you thought you had it, you could go to this traditional healer and buy this potion. But the trouble was that in Ouige, and this isn't true in all of Africa, but certainly in this corner of Africa, it was felt that the only good medicine was injected. So this potion, which I don't think was helping people very much, was given to people with dirty needles. So somebody who was a little sick, who may have been infected with Marburg, would come along and get his shot of Marburg protection drug, and the next person would come along who maybe wasn't infected, and they would get a shot in the same needle, thereby exchanging blood and spreading the disease. This was another communication challenge that we had. I like this picture because I think it shows exactly how the population felt about us for the first 3 weeks we were there. This little guy was being taken to a hospital. He'd been in contact with a Marburg victim, and he was being taken for testing. He would be isolated in the hospital, and the way he's looking at the WHO worker, I think, just says a lot about how they felt about us. This is a bad photograph, and because this healthcare worker should be better protected. He certainly should be wearing his mask. But I think what this says is that in these kinds of situations, when a child is crying, when they've lost their family, it's very, very hard to maintain that equipment. This now is, you can see these people dressed in personal protection equipment. This is now our major concern, a virus H5N1. This is a highly pathogenic avian influenza virus. I spend my life talking about this now, and I don't know if it's actually something that's you've spent much time thinking about or hearing about, but for the last 3 years, we've been talking a lot about how this virus is a virus which can ignite the next pandemic. This is a scene that it's a picture, it's a classic picture that usually goes in every pandemic presentation that I've been to anyways. It's a makeshift hospital from the 1918 Spanish flu pandemic. 1918 was actually the single most deadly infectious disease event in history. For that short a period of time, nothing, not the Black Death, nothing killed more people than this pandemic. And so what we hear a lot now is, the pandemic's coming, and then they show this picture. This is a huge communication challenge. It's a communication challenge for us because we really don't know what the next pandemic will look like. We don't know how deadly it'll be. We have lots of ideas. We have a couple nightmares. But we don't know when the next pandemic will start. There certainly will be a pandemic. There's no reason to believe that there won't be a pandemic. They've been documented since the 1500s, and really there will be another pandemic. We don't know if it'll come from the virus that we're monitoring, but this virus has 2 of the 3 characteristics of a pandemic virus. It jumps from animals to people. and it causes severe disease. It causes severe disease because this is a virus entirely new to the human immune system. Should this virus acquire the third characteristic, and that is easily moving from one human being to another in the same way that seasonal influenza moves, that would ignite a pandemic. And what that pandemic would look like, nobody can say. Many of you may have lived through one pandemic, the 1968 pandemic, and when you tell that to people my age anyways, they will certainly not remember that as a major public health event. That's because fewer than 1 million people died in that pandemic, an excess number of deaths worldwide, that is. So it was a very, very mild pandemic. So all pandemics are not like 1918, but they're certainly not all like 1968. So how do we communicate? How do we talk about what the pandemic that people should prepare for, that nations should prepare for? How do we tell them about what they should prepare for? And so this is where I want to jump back to SARS, because it was SARS actually that allowed WHO to develop the foundation for how it talks about outbreaks and other events, other public health emergencies. When I came to WHO, there was a lot I didn't know, but the most important thing I didn't know was there was no real communication structure. Not only was there no risk communication structure, and there was none, there was no communication structure at all. The new Director General had decided that divisions, departments could have their own communication person, although they didn't give them terms of reference so they would know what that job was. And people who were running these departments thought that the best communicators were reporters. I don't think that's true. I think reporters spend most of their careers being used by communicators. And so those are the people they should have been hiring, but they went out and they hired people like me. And then SARS came along. This is a sketch of an event that occurred in Hong Kong in February of 2003. A man staying in the Metropole Hotel, he was a physician from the province of Guangdong, which abuts Hong Kong, came to this hotel. He stayed one night. He stayed in room 911. And all the little figures that you see, the boxes are rooms on that floor, but the figures you see are the people he infected in that one night. The next night, he was in a hospital. The night after that, he was on a respirator, and shortly he died. Nevertheless, these people, very few of them lived in Hong Kong. Why would they? They were staying in a hotel. They began traveling. They went to Hanoi. They went to Canada. They went to Singapore. They just started spreading the disease all around. And it wasn't very long before we had reports of a very large outbreak. We'd actually had reports coming in about this time. It took us months to piece together this information. But about this time, we were getting reports into that 9 o'clock meeting that I showed you of strange events, strange happenings in Guangdong, the province of Guangdong in southern China. There was a big run on vinegar. Vinegar is thought to be a disinfectant, and it's something that the Chinese buy in great quantities when they're concerned about flu or whatever. So there was a big run on vinegar. We began getting emails and SMSs. SMSs are a very important communication tool in Asia, and especially in China, about strange infectious disease events. There was one report, which turned out to be true, of a patient who was transferred from one provincial hospital to a large central hospital. The people who transferred him in that ambulance the nurse, doctor, and driver all became infected, and they all died. So we'd been picking up these reports. We were asking the Ministry of Health of China about them, and we were not getting any information at all. And then this event happened. We were completely unaware of it until we began getting reports first from Hanoi. One of the people who had gone to the Metropole Hotel, a New York businessman, went on to Hanoi, became very sick, and was put in the hospital. He didn't respond to antibiotics, and his condition declined. That's when this man in the brown suit, Dr. Carlo Urbani, who was our infectious disease person in Hanoi, was called to the hospital to look at this guy. He was concerned, very concerned actually. He looked at the test results. He gathered samples from this person and had them sent again to the US CDC. Dr. Bani was a very interesting guy. He worked, like a lot of people, he had worked at MSF, and he was head of the Italian MSF. He was part of the small group who picked up the Nobel Prize that was awarded MSF, I think, in 1999. Dr. Bani became sick himself. And he would, within a month of visiting the hospital, he was dead himself. So shortly after Dr. Bani was hospitalized, we realized, and the government of Vietnam realized, that they needed assistance. And so there was a global network that we have at WHO. It's sort of like a group of volunteer fire department people, and they work at different institutions all around the world. And we can say that we need an epidemiologist who speaks Portuguese for a place like Uige. We'll put out that alert, and then we'll get back volunteers, people who fill the requirements. This is the team that assembled in Hanoi. This happened at a time when there was a lot of global bitterness about what was going to happen in Iraq. There were arguments in the UN in New York and globally about what was going to happen. But this is truly an international team. We have people from France here, from Italy. The woman I care for dearly, Dr. Eileen Plant, is in red, and she was the team leader. All of these people received and responded to a notice that said, we have an outbreak of an unknown disease, and it's so infectious that it's claimed our infectious disease expert. And do you mind giving up everything you're doing and going off and responding to this outbreak? And we had a number of people who replied. And it was a good thing that we had a large number of people who replied, because these people all needed to be changed out. The outbreak went on for such a long time. This is another spreading event. And this is an image that actually, I'm not a comfortable flyer. And so this is something else that adds to the things I think about when I'm on an airplane. Anyways, I don't know if you can make it out, but the man in red is the person who's infected when he gets on this plane. All the other colors are people who were infected when they disembarked from the plane. So this was a spreading event that occurred on an airline. This, too, actually, there's another story about this, and that is that one of the people on this airplane was a Chinese official. He becomes somewhat sick, but he goes on to a meeting in Bangkok. This is a flight from Hong Kong to Beijing. This person goes on to Bangkok shortly after this flight. And on the flight back, he sits next to an ILO, an International Labor Organization official, and he infects him, and that person dies. So this is what we think about when we think about disease-spreading events. When we think about how H5N1 would spread, we think about situations like this. The Hotel Metropole and this Air China flight. Actually, SARS was not that easily spread. It was what we call short distance droplets. So about 3 feet or so, 2-3 feet, if you were in coughing range, you might become infected, and that's why a lot of hospital healthcare workers became infected, because they worked around patients often without protection. Pandemic influenza will spread in an entirely different way. It'll be much easier to spread. Many people in this room would become infected if I were infected. It isn't just 3 feet away. It's a much greater distance. There's an argument there. It's unclear what that distance is and what the spread is like, but it's certainly spread much easier. So when we think about how a pandemic virus would spread, we have an indication of how it might spread from these spreading events, but it would be much more severe. So the life as a communicator during an outbreak is, especially a global health event. In journalism, they say if you go to work in public relations, like I did, I left journalism and I became a FLAC for the World Health Organization. They call that crossing the street. At least they used to call it crossing the street. You work on the other side of the street. I don't think that's right. You work on the other side of the wall, because it's very hard to see what's going on. I realize now that a lot of what I did as a reporter was a gross approximation to what was going on. If I worked very, very, very hard on something, as I did with the Clinton health care plan, I worked 3 months inside the White House while they were developing that plan. It's still an approximation. But what you don't know is on the other side of that wall, that's also an approximation of what's going on. They don't know. They've got an idea. They certainly have a better idea than any reporter would have, but there are lots of things they don't know. Nevertheless, we began getting hundreds of calls, and literally thousands of emails. So I was pretty much alone, and we went out and I made a case for hiring another person. So we doubled our communications staff, and very quickly learned that there's no way we can respond to this. I was taking calls at 3 a.m. from reporters in Hong Kong, and they would go right on through into the midnight or later from reporters in Toronto or on the East Coast. It just kept going on and on and on. And initially, I thought it's important to respond to as many people as possible. Big mistake, but I thought that what we should do is just be out there and answer every question until we can't answer questions. The problem is that you just physically can't do that. So we had to develop a couple ways of responding to questions. We developed a web update in which from the day before, we thought we were hearing the same questions over and over, so we would do a web update the following day answering those questions, and that went out every day. We also developed something we call the virtual press conference, which is something else we stole from CDC, and that is because Geneva is actually in a little remote corner of Europe, it isn't a big news hub. We set up a way for reporters to call in, and we had a video feed going out and radio quality sound, and we would sit down for an hour or 45 minutes usually, the best expert that we could find on our team who had some time to talk, and that usually No one really had any time because we were all working very long hours. We were working every day, 7 days a week. We had this emotional blow of losing Carlo Urbani. We didn't really know, is this just the beginning? It seems to be limited to hospitals, but then there was an apartment building in Hong Kong, Amoy Gardens, where a number of people became infected as the virus changed. So there were lots of things that kept us on edge. It was a very, very tense time, but one of the interesting things is that there were no big shouting matches internally. There was a lot of pressure, there was certainly a lot of emotion, but it didn't spill out. Actually, it did when it was over, and it was kind of unpleasant for a while, but during that time, people just kept working. Our lead influenza person, Dr. Klaus Storr, his mother became very sick. She was taken to the hospital, she lingered in the hospital, and she eventually died. He never attended the funeral. He didn't go to the hospital. There was, I think that's the most extreme example of personal pressure, but there was a lot of personal pressure on this very small team. I heard that CDC at the time had something like 33 communication people working. Is that right? Something like that? We had 42 people in our entire group. You counted everybody. We had 42 people. So it was a lot of work for a lot of people. We learned a few things. I like this because it's time. It has no real meaning in here. One of the things we wanted to know was how honest should we be? I felt that we were doing great work. We were a small team working hard. And I thought all we had to do was throw the door open, allow people to come in, say what we thought at the time, just to be a good source. This is what I thought. And one spokesperson at WHO said this, and this appeared in the Associated Press. It ran worldwide. He said, people are not responding to antibiotics and antivirals. It's a highly contagious disease, and it's moving by jet. Until we can get a grip on it, I don't see how it will slow down. It's bad. I think that now is not a very good quote. Why isn't it good? I think it is accurate. It's how I felt. That's me. It's how I felt. It's how many of us felt. We were very, very anxious about this. I think what's wrong with this quote is the line, I don't see how it will slow down. And I would not say that again, because I do know how things slow down now. This is just a lack of experience. The other outbreaks I showed you, the plague outbreak in the diamond mine, in the Marburg in Liège, they all use the same basic techniques of contact tracing, isolating people, pretty rudimentary stuff. But it works. And it worked for SARS, and it worked for those other diseases as well. How am I doing? Not too well. Okay. So after SARS, we decided that we better have a more solid intellectual foundation for what we were going to say with our communication. And we developed something I'm very, very proud of, although I played a minor role in it, and that was to develop outbreak communication best practices. We spent a year going through the literature. We found what we thought were 5 important features that influenced communication during an outbreak. We took those 5 features to a meeting of 85 outbreak managers that we brought together in Singapore. And we asked them to look at these features and to get their feedback. They endorsed these features, and now these are what we're telling countries. This is the guidance we're giving countries about how to communicate during outbreaks. And it's interesting. The number 1 feature, the overarching communication goal during an outbreak is to communicate with the public in ways that build, maintain, or restore trust. I thought the outbreak managers themselves would not agree with that. I thought the most important thing they thought was that we got to control the outbreak. But as you saw in Liege, you have to be able to listen to people, to build their trust, to relate to them in a way that they'll actually do what you say. So they endorse this trust feature. This first announcement is something that troubles a lot of countries. We encourage them to go out as rapidly as possible. It's very difficult to do because the information at the beginning of an outbreak is uncertain and incomplete. They're very likely to be wrong. New York, when it announced West Nile virus, said that this was St. Louis encephalitis. And they were wrong about it, but they were right about how it was transmitted. And so going out early allowed people to take measures that protected them. Even though they were wrong, they did the right thing. We encourage transparency, that communication should be easily understood, complete, and free of deceit. That's an important phrase and very difficult for some countries to do. We now call listening communication surveillance because it sounds technical. And all of this has to be planned in advance. Essentially, and what I don't tell people is that this all adds up to tell the truth as fast as you can and then listen to what people say. This is my boss now, Margaret Chan. Margaret was head of the Hong Kong Department of Health during the first H5N1 outbreak in 1997. And she and I have talked a long time about how we communicate about the pandemic. And the best thing we can say really is that we don't know. We've gone 3 years now without a pandemic that we've been warning about. Is this the Y2K of public health? Answer is we don't know. When is the next pandemic going to start? How bad is it going to be? We don't know. It's the most honest answer we can give. It's unsatisfactory, but that's where we are. This slide is supposed to tell you that we've been teaching countries to follow these best practices. And actually, Egypt is one of the best countries to employ this. Egypt has a very, very bad problem with H5N1 now. It actually had a cluster of cases of Tamiflu resistant, and that's the only drug really that works against H5N1. People actually developed a resistance to this drug, and it was a very difficult position for Egypt to talk about because Egypt is especially dependent on tourism. So to talk about having the next pandemic in your country and that it's now resistant to Tamiflu was very difficult for them to do, and nevertheless they've done it. I put this up because I think it's the best example of countries using outbreak communication techniques right now, but at the same time, I've worked with a government in Africa that had a hemorrhagic fever outbreak, was in a meeting with the Ministry of Public Health in which they had planned in detail how to get rid of bodies, using the military to move bodies and bury them in the middle of the night so that people wouldn't be afraid and panic. So we're making some advances, but you move ahead and you slip back. As I was preparing for this, I read through, again, Carlo Urbani's Vietnam journal, and in it he writes that the joys of life, to savor that each horizon brings, to offer this to your children, to get excited with new discoveries, to rejoice in sharing. This fills my heart with energy and allows for the work that one does to improve some small corner of the world. This is productive. More than worrying about how much I will learn, I will worry about how well I work in the movement towards poverty alleviation and the access to health care for the forgotten. And that's Carlo. Thank you very much.